you all while you're taking your test, I thought we could mark the progress of time by how short Brad's hair gets by the end, and how many top knots there are in the morning. There were 10. I counted them. Because by the time I see you all, your hair's down, like Taylor, Kendall, Lindsay. But otherwise, there were 10 top knots this morning. I don't know what y'all call them, but I thought the further we go, the more there are first thing in the morning.
I almost thought our first last thing is I don't want to.
I like it.
I'm on a diet.
Yeah.
I'll eat
Don't buy things you don't want to eat.
Yeah.
It's hard, but
Upper crust, right?
I've never had it.
I haven't had the
I was kind of nervous that
Well, you do so much for that.
It's too good.
like Send anyways, and then it's like,
Okay.
okay, I'll
Let's
fix
start
it in a
peptic
minute.
ulcer disease. So have you talked about peptic ulcer disease?
Yes.
Okay, so the two big ones we're going to worry about are non-steroidal and H. pylori. So non-steroidal is common cause of peptic ulcer disease. So is steroid use. So be really thoughtful of that problem in patients who take them long term. So one of the big things with non-steroidals is have them take it with food, something on their stomach. That will help a lot. You can also use it with a PPI if it's really irritating. Risk factors are listed there in the middle of the page. These are ones you have seen before, so it's going to be your older patients, those over 60. People who've had a history of ulcer disease in the past are going to be more at risk. High-dose steroids, long periods of time, those are your at-risk folks. The H. pylori, there are new guidelines that came out in January of this year, and I posted them to the D2L for you, and then gave you the citation here. Well, I didn't give you the citation, but it's the American College of Gastroenterology. So there, I noted some change that I had seen from the last year in their approach to treatment. So on page 12, our goals of treatment, of course, we want to make the patients wants to feel better. They're going to come to you because their stomach is hurting. So it's to heal the pain, heal the ulcer, prevent the recurrence is a big one, and reduce ulcer-related complications. So these folks can have significant blood loss. I read one time that you can lose as much as 5 to 7 mils of blood from a peptic ulcer over time, and so they can get anemic with long-term use. So with non-steroidal induced ulcer therapy, stop the agent if at all possible. Use a proton pump inhibitor to help with the belly pain. Let's see, that's about it. What I want to concentrate on really are the H. pylori treatments, since they have changed somewhat. So it's a gram-negative organism, you know that by now. So the big first branch in terms of treatment decisions that you have to make is, are you in a macrolide resistant area or not? So all throughout this year we have seen this. It's one of the most common things you have to think of. Is the resistance high in your area to an antibiotic that you're going to use? Macrolides have been around forever, but we throw them around like nothing. I bet most of you have been treated with one at some point in your life. So that resistance level is now gone up to the point where it is starting to affect the effectiveness of treating H. pylori patients who have peptic ulcer disease due to H. pylori. So deciding that is the first. One of the authors I read said that for the most part it's not always available, or information is easily attained whether in your area that is a problem or not. So these authors made the assumption that it is just endemic, that throughout the United States we probably have greater than 15% resistance of people to macrolides. And then the other decision would be, are they penicillin allergic or not? Because most of the First-line therapies, combination therapies are going to include amoxicillin. So those are the two things you have to ask yourself. Is resistance likely? Have they had a penicillin? Do they have a penicillin allergy? So risk factors for macrolide resistance are listed there, and these are important. One is, have they ever been exposed to macrolide therapy? If they have, then it's likely that they are colonized with organisms that are resistant. So one thing to ask about from your patients. So going down to the last two areas there in bold, patients with risk factors for macrolide resistance, they recommend using the bismuth quadruple therapy. Did you all talk about that? Yes, okay. Patients without risk factors would then use the clarithromycin-based triple therapy, which is clarithromycin, amoxicillin, and PPI. The alternatives is the bismuth quadruple therapy. So let's look on the next page. Under first-line options, I've given you a little bit about each of those. So the first one is the clarithromycin-based triple therapy, very common. I've seen and heard it used down in our patients at Good Shepherd. The next one is the bismuth quadruple therapy, and then the last one is a concomitant therapy. There are 8 different regimens that are now out there. And the ones, I just gave you the first 3, or these 3, because they're considered first line. They're also considered to have enough data behind them that evidence is good. Or if they don't have the evidence, they are in such widespread use with good outcomes that they have attained this first line status. Some of the data is from worldwide, and it may not be in the United States data, so they take that into account. Other regimens are what they call sequential regimens. What they'll do is they'll take 4 drugs and they'll give 2 of them for 5 to 7 days, stop them, and start another 2 antibiotics for 5 to 7 days. Those have a lot of use outside the United States, but don't really have US data, so they're not recommended as first line. Some of them use fluoroquinolones, and that is an alternative if you've got people who don't respond or are penallergic or cannot use the other agents. There is a fluoroquinolone. So realize that there are multiple regimens out here. The 3 I gave you are the 3 highest evidence behind them and most commonly used in the United States. Realize that there is also increasing resistance to metronidazole, but it can often be overcome by giving higher doses or for longer periods of time. Amoxicillin also has some resistance, but it is very low, and it doesn't seem to be growing as we see with others. So resistance to amoxicillin is usually less than 5%. So those 3 drugs are somewhat of the mainstays. You also will see tetracyclines introduced in others as well. So let's go through each of these. So what were you told in your when you all did it in ClinMed?
You said clarithromycin, PPI, and bismuth compounds.
Yeah.
Some kind of antibiotic and then hydrogen potassium, ATP.
Say that again?
The proton inhibitor.
Oh, okay, okay. So they talked about the bismuth quadruple.
He just has it listed. He didn't really I don't remember.
It wasn't
all
as
the
detailed and.
Okay, all right. Did they give you multiple ones? Did they give you a go-to? Okay. All right, so first line, so this clarithromycin-based triple therapy, very commonly used. So it is a combination of omeprazole or a PPI, and it is standard dose. But you'll see here, and Travis, this is what I kind of tripped myself up on, is that they will give it twice a day instead of once a day. So standard dose, twice daily. And then the second antibiotic is the clarithromycin. That's where it gets they pull the name from. And then the third antibiotic can be metronidazole if they're penallergic, or amoxicillin. Okay. Note the duration. Duration is important here with this one. They have found in the past it's been given 7 days, 10 days, and now 14 days. So they find the highest eradication rates are when people take it for 14 days. So that's what I would base my therapy on now is the 14-day. Ask patients if they've used macrolides in the past. Most people you're going to find probably have been on one. And their recommendation is move off, then move on, choose another one. I looked at the CDC's, which is behind. Not behind, but they haven't updated their guidelines that I could find on their website to the same extent that the College of Gastroenterology has. Okay, let's look at the bismuth quadruple therapy. Again, a first line. Use it in people who have that exposure to the macrolides or in regions where there's high clarithromycin resistance. Can be used in penallergic because if you look down through there, there's no penicillin. Use it for 10 to 14 days. It has a high eradication rate of 91%. So why not go to it? Well, it's a 4-day it's a 4-drug regimen. That's some of the problem. So again, it's a standard PPI. It is bismuth that gets added, metronidazole, and then a tetracycline. I want you to know what these are made up of. I'm not going to ask you the doses, but you've got to know which drugs are part of these different regimens. The last one is called concomitant therapy. And the reason for that is that it takes all those antibiotics, they combine them together. So that's kind of how it's got its name. Another first-line option, all the things we talked about with macrolides before would be part of it. Penicillin allergic patients are not going to be able to use it. So again, it's a PPI. Doesn't have to be omeprazole. It can be any of them. Clarithromycin, metronidazole, and amoxicillin. And it is a 10 to 14-day recommended regimen. So know those. Know what makes up what drugs make up each of those three. Confirmation of eradication should be made in all patients when you treat. The biggest reason for failure is that people don't take it. It's a complicated regimen. They've gotten it down to where most of the antibiotics are twice a day, but metronidazole is still 4 times a day. So it's hard for people to comply with, even though you're talking about 2 weeks. So that's the #1 reason why they fail. It could be a resistance of the H. pylori to one of the medications that you've used. The other is to think about that it could be another bug. It could be Campylobacter, it could be Giardia, Shigella, different organism that's causing it. If you look down under factors, the last bullet, clarithromycin resistance plays the highest role in failure. Metronidazole can, but usually we can overcome it, as I stated before, and amoxicillin, usually the rates of resistance are low. Okay. So salvage therapy, well, what do? Sometimes people get treated 1, 2, 3 times and without clearing up the infection. So patients who have persistent infection, try a different method, but don't use the same drugs that you did in a regimen that failed. Again, here you might have to go to the guidelines or to the CDC and look at what your options are. Again, fluoroquinolones are probably one of the more common ones used when you've got, if you haven't used them, to use them in a regimen, in a subsequent regimen. So I listed some of them for you. The bismuth quadruple therapy, the levothyroxine triple therapy, again, levothyroxine, amoxicillin, again, because we don't suspect amoxicillin is the problem, or a high-dose dual, so that's amoxicillin with a PPI. And the last one is rifabutin. This is a really good antibiotic. It's not used very often. It's very expensive, so more considered a second line or in the salvage regimens. And it has a myelotoxicity, which makes it a little bit more worrisome to use than the others. Okay. Does that contradict anything you heard in your ClinMed? You know, if you've been down to Good Shepherd, you've already know this is common. So peptic ulcer disease commonly happens. So watch for changes in those recommendations. This time was a fairly different from the times before. Okay, nausea and vomiting. Next one. Have you had anything on it that's talked about? People do chemotherapy, so you usually see that a lot with that one. Okay, so nausea and vomiting can be due to lots of different areas of the body, and some of them are listed in this diagram for you. But they can be divided into 3 different areas of the GI tract or in the brain under number 3. So it can be a direct insult to the stomach. So it can be GI tract irritation, toxicity due to a drug or something that they've eaten. Or it can be something that has triggered the chemoreceptive trigger zone that's in the medulla. And you'll note there, as we're going through, there's lots of neurotransmitters that are involved in these different areas. So in the brain, you got 5 different neurotransmitters. So people use drugs that affect those neurotransmitters to decrease the nausea and vomiting. So you'll see drugs coming in that you wouldn't necessarily have thought that you would use them for that. So the serotonin receptor antagonists are often used. The drugs that work on dopamine or histamine are commonly used in this. So anything that hits a neurotransmitter usually will have some effect in this area, the opioids as well. The last one would be vestibular apparatus. So you know motion sickness, if you're got sick, car sick, and out on a ship. So those are your motion sickness. On the next page, page 16, they're the ones that are listed, so we use muscarinic, dopamine, histamine, serotonin, neurokinin, blood receptors, and substance P. And there's a chart. I'm not going to hold you responsible for this chart, but it shows you, based on the situation and what neurotransmitter is usually involved, then what type of antiemetic people usually will choose. I don't find that most people are that thoughtful. They usually have a go-to, which most people will start with a prochlorperazine or a dopamine agonist or antagonist, unless it's chemotherapy. Then those are very specific and very protocol-driven. Under that table, so drug therapy blocks the stimulation of at least one of those neurotransmitters. With nausea, if you have control of it, prevention is best. So you'll see with a lot of chemotherapy, they'll give a lot of pre-treatment just to keep the person from getting nauseated. Nausea is also something learned. So we used to see it with chemotherapy is that you give a person a drug, they get very sick off of that. The next time before you even give them the drug, they'll start throwing up. So they will do a lot of work to keep that ever from being learned behavior when they're giving chemotherapy. Steroids, different antiemetics are effective for different types of chemotherapy. Oral is just as effective as injecting somebody. So sometimes you can't give people stuff orally because they'll throw it back up. So you've got rectal routes, you've got IM, you have IV routes that you can use. Use the lowest dose. All of these drugs have significant side effects, especially those that work on dopamine, because you can get all the EPS reactions. We talked about those in psych. Remember Dr. Britton, Amy talked about her husband, some of the rest of you talked about getting dystonic reactions. And you can see it on the first time you do it. So be mindful that these drugs are very powerful and can have powerful side effects. The other is, the one, and I'm going to violate this rule even though I've put it in red, do not give antiemetics if vomiting is likely from an infectious cause. It's one of the ways the body gets rid of toxins. But there also comes a limit where people can't tolerate it any longer. So you have to kind of balance their comfort in what the body is trying to do to address an invasion. Next page, page 17. These are some of the agents. I just pulled representatives for the different classes that we're going to go through. So the dopamine receptor antagonists, these are very common. This is probably a go-to for most people. And prochlorperazine is commonly used. It comes as, you can give it IM, you can give it PO, it comes as a suppository as well. It's a central actor. Usually if you can centrally affect the chemotactic or chemoreceptor trigger zone, you can control most nausea and vomiting. The problem with it are it has cardiac arrhythmia, so QTC prolongation is a problem. So in your older patients or people who have congenital QTC prolongation, or if they're on other drugs that cause QTC prolongation, which would be what? What drugs have we talked about?
Fluoroquinolones.
Fluoroquinolones, what other antibiotic? Macrolides, okay. What else? Ondansetron, which we'll talk about in a minute, another antiemetic. So keep those big ones in mind because they may be on those and you're treating over it. EPS, so on the next page there's pictures of some of the dystonic reactions that can occur with these drugs. It's moderately effective for nausea, but it's highly sedative. So often you just knock them out with this when you give it to them. They'll go to sleep. And so that may be merciful in some situations. But they're not very effective for chemotherapy. But for most nausea and vomiting not due to chemotherapy, they're pretty effective drugs. Metoclopramide is a very unusual drug in that it hits almost all of the neurotransmitters. It works on dopamine, it works on serotonin, has histamine effects as well, cholinergic receptors, so that's why it's so effective. It also is a prokinetic drug, so it keeps the gut moving in the right direction. So when people get gastroparesis, this is a drug we commonly go to, and they often get nauseated because the food just sits in their stomach for long periods of time. So those prokinetic motion and the fact that it hits all those receptors or neurotransmitters makes it a pretty good drug. The downside is that if you've got prolonged use with it, like you can see with gastroparesis, you can get the extrapyramidal reactions can occur, tardive dyskinesia can occur as well. Just a reminder, if you look on the next page, this is an example of some of the dystonic reactions. You see torticollis on the left-hand side. Remember that is an involuntary muscle contractions, and it really twists their neck over to one side, and they cannot control that movement. The buccolingual crisis, I think I showed you this guy on a video. Remember, he just couldn't talk. Mouth is just stuck in that position. The trismus, the involuntary squeeze, closing of eyes and opening. There's another lady with buccolingual crisis. And then I could not find a picture of opisthotonus, but this is I don't even know who drew it, picture of someone who has drawn that. Okay, questions about those, just a reminder. Okay, let's look on page 19. So these are the H1 antagonists. So we're back to the H1, the antihistamines. So they're pretty good for nausea and vomiting, very good for motion sickness. This is what most people use. So like if you're a kid and you couldn't ride in the back seat because you couldn't see out, Dramamine might have been given to you. You might take it now if you're having to go long distance and you get motion sickness. People who go on ships, they use these too, like in the form of scopolamine. So let's kind of run through those. That's where they probably are the best. Again, you would avoid them in any conditions where you could worsen the underlying condition. So these would be the drugs that are on the Beers list. So using them frequently in the elderly, you would probably not want to do. People have glaucoma, men who have BPH, would be folks who could have aggravation. And the anticholinergic symptoms or side effects are going to be present if you use it enough. So the constipation, the dry mouth, urinary retention, blurred vision are your main problems. So going down through there, you'll see that they are over the counter. So Dramamine or dimenhydrinate, it is a cousin to diphenhydramine, it's just a different salt. Promethazine falls in this, even though it also has central action and dopamine, it just has antihistamine action as well. So a very common one, Phenergan's a common one to use in acute situations because you can give it by all different routes. Very sedating drug, as these are also. Meclizine or Antibert, Bonine, over the counter, commonly used for motion sickness, also for vertigo. So for vestibular associated nausea, those drugs work as well. So under promethazine, because it works on dopamine, remember the EPS, it should not be used IV or sub-Q. It is given IM. Can be used by suppository or PO as well. And then if you look on the next page, that's where the transdermal scopolamine is used for motion sickness, particularly when people are going to do water travel, common. The good thing about this one is you can apply it ahead of time, and that really helps decrease their motion sickness. So it's a patch, goes behind their ear. They can apply it up to 4 hours before they're exposed, and it's a 72-hour patch, so they only have to change it every 3 days. All the same side effects. I think it only carries the indication for motion sickness. I don't know of any other uses, even though I'm sure people do use them for other things. Questions about those, the antihistamines? Okay, the serotonin antagonists. These have become very popular because they're very effective. They don't cause many other side effects. They're more expensive. They're also good because they have dissolving tablets, some lingual tablets, so they're very easy to give to people. Oral solutions. Ondansetron or Zofran is probably the one that has become very popular, but it is one of those QTC prolongation drugs, and so it has a limit on them as to the amount of dose that you can give, and that's 16 milligrams. That's an important one to keep in mind because it's a common drug used. Dose is usually 4 to 8 milligrams at one time, so it doesn't take very long before you can hit that 16 milligrams in a day. Often used for the serotonin antagonists are really good for chemotherapy-related nausea as well. Okay, so let's go back, just thinking back through those. If it's vestibular, then look at the antihistamines. If it is gastric, or if you want to hit central, then your dopamine agonist or dopaminergic antagonists are probably the best overall. So promethazine or prochlorperazine are very good. If you need a prokinetic, then Reglan or metoclopramide is the one to go to. And then if you've got more, if they don't respond to that, or you've got more chemotherapy that they're walking in your ER, then your serotonin antagonists are your good ones. Any questions or comments about that?
I think Phenergan comes in a topical gel too.
Yes, it does, and that's become real popular. I've forgotten about that. Yeah. Lots of people like that.
I feel like meclizine might too.
Pardon?
Does meclizine come in the topical as well?
Now that I don't know. I'd have to look. I'm not familiar with it. You heard what Amy said, that Phenergan comes in a top. Does that come commercially available, or is it compounded? Mhm.
I know it's called promethazine.
It's called what?
Just the promethazine.
Oh, okay.
I was gonna be really sick again, having to make it and not having gloves on accident.
Every time I get it, it knocks me out for about 12 hours. I just can't even function. Okay, page 21, so constipation. Have you all talked about this, or is it coming in? Coming in, okay. So drugs used in constipation laxatives. So it's defined as difficulty passing stool, less frequent defecation, lower stool volume, hard or firm stool. Constipation and diarrhea are two terms that are relative. So when patients tell you they are constipated, that's where you have to start asking them, okay, what does that mean to you? So somebody that is used to going every day, if they only go 3 times a week, that's a big change for them. If somebody's used to only going 3 times a week, and they go once a week, that may be a big change for them. So you have to establish what is normal for you, what has changed. Okay? Often it will be a change in diet. They've done something different, or they're not drinking enough fluids, or they're sitting, or they're very inactive. Those are common reasons. They're not the only reasons, because there can certainly be other things. Drugs are a big common reason for constipation. So looking for, on their regimen, what could be causing it. Look for a new drug, look for a dose increase, look for interacting or compounding drugs. Maybe they're doing pretty well with one drug that could slow their gut down, but then you put a second one on top of them, and now they can't go, and they're miserable. They feel bloated, and they're complaining. So the worst end of it is if they get impacted. And that in the elderly, common visit to the ER. So, and we want to avoid those, especially in the older age group. So I listed most of those. Medical conditions, medications, failure to heat, urge, or improper bowel habits. So a lot of the recommendations are bowel training, teaching patients to go at the same time every day, or when you feel the urge to go, go. Don't put it off, because the body will then become less responsive and may not tell you as often. So the different laxatives that are available are stimulants, stool softeners, osmotic laxatives, and bulk-forming agents. If at all possible, if you have somebody with chronic constipation, work with them on lifestyle changes. Again, most of the time it is diet related. People don't eat enough fiber. They don't drink enough fluid. So working with them on getting an adequate fiber intake. How much fiber should you get every day? So at least 20 to 30 or more. In the United States, I think it's under 15 is common. We just don't tend to eat a lot of high fiber. If you don't eat a lot of vegetables or whole grains or fruit, you probably don't get much fiber in your diet. Okay, so let's look at stimulants. So stimulants are, they are a local irritant to the gut. So they make the gut contract and expel whatever is in that part of the intestine forward. So that's why they're called irritant or stimulant laxatives. They are not recommended as first line. They're usually used as add-ons to a different type of laxative, or they are for very minimal use. Because if you use them regularly, the gut will become dependent on them, and it will be hard for them to establish regular bowel habits if they are constantly using a stimulant laxative. So it's one thing to ask people if they are chronically constipated, is their use of laxatives. Young girls, women will use it as ways to control their weight as well. So stimulant abuse is not uncommon for people who are trying to control their weight. Do note down there under the third bullet under clinical pearls, this is the preferred agent for opiate-induced constipation. Because that is really a slowdown of the gut that the opioids do, and they're really bad about it. Everybody who takes opioids will get constipated or have a decrease in bowel movements. So two of them, these are not all of them, but they're the common ones, are bisacodyl and senna. Both of them are over the counter, so people can go get them and treat themselves as long as and as much as they want. So it comes orally and rectally. Senna is only a tablet that you can take. They are, the other is dosage form will make a difference of how fast something works. So usually rectally administered products like a suppository or an enema will work fairly quickly. If you take it by mouth, it will probably be 6 to 12 hours before an effect is seen. So you'll see a lot of older people will take a laxative at night so that they can have a bowel movement in the morning. So kind of keep those things in mind, so when you're asking folks, you can look at those kind of common behaviors. So that's stimulants. Stool softeners, the concept is great, it just doesn't work that well. They are surfactants that reduce the surface tension and allow water to move into the stool and soften it and make it easier to pass. So the problem with stool softeners is that we usually underdose it. These are not drugs that are usually toxic, so we need to up the doses of them. And people need to drink a lot of fluids with them. Not a lot, but at least a glass of water when they take it. A glass means 8 ounces of water. So that's why stool softeners usually don't work, is because we just don't dose them enough or high enough, or people don't take water with it. They're preferred in the elderly, in pregnant patients, because they're very safe. But so you can think about them. If people did overuse them, they would get diarrhea, but I've never seen anybody get diarrhea from stool softeners. I guess it can happen. So keep those in mind, but dose them up. Dose at least 300 milligrams. They come in 100, so I'll see people dose 100 milligrams once a day. You might as well spit in the wind. So about 300 milligrams is a good starting dose. I put there that you can use up to 50 in 1 or 4 divided doses. They're not, they don't upset the stomach. I mean, they're very innocuous, so easy to use for med schedule. Probably the drugs that are the go-to that most people will use are the osmotic laxatives. And there's a whole bunch of them on the market. So these are the ones people will use for acute and for chronic. So we'll talk about the acute first. So max sulfate, very common. You could buy it, what is it called? Mag citrate. Comes in a green bottle, yellow label, used to. Looks like a beer, because it has a little top that you pop off of it. It's about 10 ounces. You drink it all, and it'll make you go to the bathroom pretty quick. It also comes as in Phillips Milk Magnesia. That's the active ingredient in that one. So these are very quick in onset, about 30 minutes. So you have, if it's somebody who's really acutely having problems, these are good ones to go to. Rectal administration, you see there's a 3 to 5 minute reaction. So osmotic laxatives, what they do is they work in the colon. In most of the laxatives, that's where they're going to work. Because the colon's job is to be the final removal of water. So these drugs tend to draw water into the stool and keep it hydrated, full of water, so it will pass through the intestines faster and it'll be easier to eliminate. So that's why they're good, is that they draw water in and keep it there. So you can see that if you're interfering with the colon's job, then what could happen? Well, diarrhea if you use too much. What else? Pardon? Dehydration if you use too much. What else? So electrolyte imbalances can also occur due to that, due to the water amount of water that's drawn in. So those are the common. Abdominal cramping also just from a faster movement of the intestines. So there it is again, avoided adrenal dysfunction because of the magnesium accumulation. So older people that love to use Milk and Mag, that is one thing to oversee or think about. It's an old-timey drug, it's been around a long time, so they're familiar with it. They probably used it all their life. So keep that one in mind as one to ask about. Yeah.
Is the dosing different if you're using it as an antacid versus a laxative?
Dosing, no, it's usually 30 mils. You can use it the same, yeah,
Okay.
very same. The sodium phosphate, so Fleet enemas, another very common, over-the-counter, quick. If people really feel constipated, they'll use a Fleet enema. Older patients may do that more often. I don't know about younger patients if that's something they're used to. But you can see that in rectal, 2 to 5 minutes, very quick. The problem with this one is that it's a sodium salt. So if you have patients that are relying on it, using it a lot, then they can get a sodium overload. Glycerin suppositories. Glycerin is kind of an irritant. It will draw water into that rectal area, and it will force them to, it's kind of a stimulant as well, even though it's not labeled as a stimulant, and so they're usually pretty effective. Use it too much, you can get rectal irritation. This is one of the ones we'll use in babies. They make little infant glycerin suppositories if that is a problem in children. Lactulose and Miralax are oral agents. They're over the counter now. I put Lactulose RX, but I think it's over the counter too. Dylan, Sophie, does that ring a bell?
I don't remember.
Well, we'll go with RX because that's what I put down, but I thought it had a over-the-counter counterpart. So these are oral, so they take longer. So you can see 1 to 4 days. Same osmotic effect. They're very effective. And so for chronic constipation, Miralax has become the drug of choice. It comes as a powder. You add water and drink it. And usually it starts with 17 grams of powder a day, and you can double that up if needed. And use it. It's once a day is about all it takes. It's expensive though, but it is effective. If the patient can't tolerate or isn't getting maybe all the effect that they are expecting out of a 17 grams, you can't add a stimulant to it because you've got 2 different mechanisms of action instead of upping it to 34 grams a day if they can't tolerate that. So Miralax, you ought to be one that you're familiar with because patients use it. If they can afford it, they'll take it because it works. And they're happy with it. Very few have side effects from it. The last are the bulk forming agents. So these are more ones that are used on a chronic basis. These are the fiber-based. So psyllium or Fibercon or polycarbonyl calcium. So these are, if patients don't eat enough fiber, they can take these. If they eat enough fiber but they are looking for extra, they can do that. These are also promoted for weight loss because they fill you up, make you feel fuller and longer. So they're very safe products. If you overuse them or abuse them, I assume you could probably get diarrhea from too much Metamucil or products, psyllium products. They also lower cholesterol. So they have a lot of good effects. One thing you might think about place to use them is if patients who have really variable fiber intake and they have their bowels tend to follow that. They get constipated if they don't eat enough, but they're not consistent. So sometimes what I'll do is just have them take a consistent amount of fiber every day, and then of these products, and then whatever fiber they eat on top of that usually doesn't tend to get them into this kind of up and down with their bowels because you provided them a constant intake. So that's one of the things to keep in mind. They make sugar-free products. They have flavored products. They have orange flavored if patients don't like them. You mix them with water and drink them. They're pretty easy now. They don't have as many, they've taken a lot of the husk out of them, so you don't have as much of the, I don't know what you call it. You know, like when you make, when you first pour water into oatmeal and you kind of get the light stuff floats to the top. That's what Metamucil used to, but they've got them better formulated now, so to me, they go into solution better. Questions?
Did you say they should take the same dose every day or the same fiber intake every day?
Same dose every day of this, if that's what how you're gonna use it. Then fiber content will just vary based on what you eat. Other questions or comments? This is something you will deal with all the time, especially if you are in primary care and you're dealing with adults, even with kids. Because kids don't eat a lot of vegetables, so you'll see constipation in children as well. So being well-versed and knowing the drugs will be helpful to you. All right, let's take about a 5-minute break, short break.